Okay, good evening. Before we begin, I want to just say a few words about the Sidore Lecture series and its genesis. The Sidore Lectures were established in 1965 in memory of Saul O Sidore of New Hampshire and continue to be supported by the Sidore Family Foundation. Named for humanitarian and New Hampshire businessman Saul O Sidore, the series brings a variety of speakers to campus to address critical issues and events in politics, society, science, and culture. For over a decade, the series has been sponsored by the UNH Center for the Humanities as part of their commitment to public service and intellectual inquiry. The purpose of the Sidore Lectures is to offer the university community and the state of New Hampshire programs that raise critical and sometimes controversial issues facing our society. This is the preeminent lecture series in the UNH campus, and the Center for Humanities hopes that these programs will continue to provide venues within which intellectual communities thrive and the freedom to, quote, think differently is strengthened. A first-generation American, Saul O Sidore's business practices reflected his ethical principles and his interest in providing security for his employees. He pioneered a profit-sharing plan, instituted a pension plan, founded a scholarship loan fund to help his employees send their children to college, and he was the first employer in New Hampshire to hire an industrial psychologist and institute insured hospitalization benefits for his employees. He was also owner of the Manchester Free Press, a member of the New Hampshire Advisory Committee to the United States Commission on Civil Rights, active in Manchester's Jewish community, and a driving force in support of the ideals of humanity and brotherhood throughout New Hampshire. And so in the tradition of the Saul O Sidore Lecture Series, we welcome you tonight to the first of what will be 6 Sidore events planned for this academic year at UNH. As you can see, the series is entitled Contextualizing and Reframing the Opioid Crisis in New Hampshire, Interdisciplinary Perspectives on Policy, Practice, and Discourse. This year's series will bring together collaborators from across the College of Liberal Arts, as well as from outside the college, to ask, what can liberal arts bring to the table in addressing the opioid crisis? How can our modes of inquiry, our humanistic sensibilities, and ways of understanding and conceptualizing a problem address this particular issue in practical and insightful ways? Our goal is to use the Sidore series to prompt and guide conversations about the opioid crisis that blend interdisciplinary expertise of UNH faculty and that of national, local, scholars, professionals, and stakeholders. In doing so, we seek to reframe New Hampshire's opioid crisis from one of scandal and corruption. We all remember UNH being referred to as, quote, the drug-infested den, to one of serious intellectual and compassionate deliberation. Toward that end, this evening's inaugural event is entitled, Why New Hampshire? The Opioid Crisis in Context. Before we introduce each panelist, I would like to introduce Carrie Nolte, who will serve as moderator for this panel discussion this evening, and who will introduce the rest of our distinguished panel. Carrie is an assistant professor of nursing at the University of New Hampshire and a family nurse practitioner. Her research interests focus on communication and harm reduction. Her clinical background is as a family nurse practitioner at a federally qualified community health center. In her clinical work, Carrie is particularly concerned with engagement in care and supporting people who use drugs. Carrie is a founding member of the New Hampshire Harm Reduction Coalition that has established a syringe service program to support people who use drugs in the Seacoast area. Please join me in welcoming our moderator this evening, Professor Carrie Nolte.
Thanks so much for the opportunity to moderate tonight. I have the privilege of knowing the three panelists from three different realms of my life, which is really wonderful. So, Dr. Sherman from clinical practice in the Seacoast is a trusted specialist that I've collaborated with before. Kevin Irwin through our work around policy and syringe service programs and harm reduction, and Dr. Van Gundy through our shared roles as professors here and as a great mentor. So this is a great panel put together that really looks at three different elements, three different aspects of the opioid epidemic in New Hampshire. So just to start us off, before I introduce the panelists, the sort of sobering fact about where we're at in New Hampshire is that last year there was 487 opioid overdose deaths in the state of New Hampshire. And that contrasts with only 110 motor vehicle accident deaths. And so we have 4 times the number of people dying in our state right now from opioid overdose. And if we had discussed that, or if you had told almost anyone in the state 10 years ago that that's where we would be today, no one would believe you. And so it has been complex how we got here, and it will be complex how we get away from this. And so these panelists all have different sets of expertise in order to address that. So as we go through, each has prepared a short presentation, and I will introduce each panelist before their presentation. We'll try to hold all questions to the end, and then we'll go through those questions and look forward to more discussion. So first up we have Dr. Karen Van Gundy. She's a professor of sociology, core faculty in justice studies, and a faculty fellow at the Carsey School of Public Policy at UNH. Her research examines how social contexts shape physical, emotional, and behavioral health among rural and urban youth and emerging adults. Her work is funded by the National Science Foundation and the New Hampshire Charitable Foundation, and her work appears in scholarly journals including the Journal of Health and Social Behavior, Rural Sociology, and Substance Use and Misuse, as well as her recently published book, Marijuana: Examining the Facts. At UNH, Dr. Van Gundy has served as a mentor to countless students, and her innovative research work and longstanding community relationships address and support critical problems facing our communities, including the opioid epidemic. Dr. Van Gundy's work is a great exemplar of how UNH, as the flagship state university, truly partners with communities, and these are footsteps that I hope to follow in as a junior faculty member. So welcome, Dr. Karen Van Gundy.
Okay, good evening. Thank you all for coming. Today what I want to do is just provide a little bit of overview of how I contextualize the opioid crisis in New Hampshire. My particular emphasis is on mental health and substance misuse, substance abuse, that sort of thing, and looking at how that develops from adolescence into young adulthood, and so the kinds of things to think about there. And what I'll be looking at today when I present my analysis is the effects of depression as a teenager, in how that affects substance misuse later on, 5 years later. And so I have data where I'm looking at 2 parts of the state where we've been able to look at these patterns among youth. And I do want to say, let me make sure my clicker works. Yep. Okay, and so, so I used this drug-infested den thing. It's funny, Donna, before she said, should I say that? I'm like, oh yeah, it's on my slide. So you may recall that a little over a year ago, the president referred to, he was quoted as saying, I won New Hampshire because New Hampshire is a drug-infested den. So much wrong with this. It's offensive, of course, but he also did not win the general election in New Hampshire, and I wanted to point that out. But it did really get me thinking, though. I've been looking at national survey data, local survey data, and so forth, and did want to sort of think about where does New Hampshire fit in? So New Hampshire in context, first of all, Carrie already talked about what's happening in New Hampshire in terms of the high rates of drug overdose rates. I sort of also want to put this in national perspective. That is, what we know is the rate of overdose deaths has gone up quite substantially over the last 10 or 15 years. In 2017 alone, more than 72,000 Americans died from drug overdoses. And what this graph is showing is the type of substance that tends to be associated with that, those overdose deaths. What that blue line is that you probably can't see up there is that in the last few years, the last 3 to 5 years, we've seen this exponential increase in synthetic opioids as being associated with deaths. And this is not including methadone, but things like fentanyl. So in terms of looking at where New Hampshire stands in all of this, the CDC has recently published some research here. This is looking at the 2010 rate compared to the 2016 rate of deaths per, drug-related deaths per 100,000 in the nation. And what we can see is that West Virginia ranks #1, very high rates, but New Hampshire is among the highest, here third on the list here. In 2010, New Hampshire had 16 overdose deaths per 100,000 population. That jumped to 39 by 2016, which is not a large period of time. And what this shows us here, that third little bar down there, is that rate of change. That's a huge amount in a short period of time for a very serious kind of outcome. So the other thing I'm very interested in is talking about sort of the national context of substance abuse or misuse. So drawing from national data, looking at the National Survey on Drug Use and Health, what we know is that in 2016, over 20 million people qualified for, out in the community, qualified for diagnostic criteria for substance use disorder. And this is not including people who are in institutions and correctional facilities and so forth. This is out in the community based on reports, self-reports. And also then I wanted to point out here too that really this is driven by alcohol. Abuse dependence, alcohol use disorder represents about over 15 million of the people ages 12 and older in the nation. Illicit drugs combined are about half that. But as you can see, marijuana and then prescription pain relievers are up there. These are the drugs that are creating these problems with substance misuse. So, this gray bar here, so I wanted to look at this by age because, as I said, I'm looking at adolescence and young adulthood. But about that gray bar there on the right-hand side, that is the 20 million that I talked about. It's about 7.5% of the population. But then looking at 12 to 17-year-olds, this will be the youth when I talk about, we can see that 4.3% of those guys qualified for a substance use disorder in the last year, in the year 2016. And then this gold bar here, the 18 to 25-year-olds, 15%, more than 15% of 18 to 25-year-olds nationwide qualified for a substance use disorder in the last year, in 2016. Another thing I'm paying attention to that I'm very interested in is the increase in depression among teens, among youth. And so what this is showing us is that in recent years, we have seen an increase in major depressive episodes among those 12 to 17, that this is also increasing. And so these are things that I'm looking at in terms of national understanding. But in terms of looking at maybe where New Hampshire falls in here, this is a map that's showing the red parts are the highest rates, the states with the highest rates of past year major depressive episodes among youth aged 12 to 17. The second highest is the that sort of orangey color, and New Hampshire falls there. So New Hampshire has higher rates than nationwide compared to other states in terms of the number of 12 to 17-year-olds who qualify or who have a major depressive disorder. By the way, this looks more New Hampshire, when we look at 18 to 25-year-olds, New Hampshire is that burgundy color. It's one of the highest rates. And when we look at that 18 to 25 age range, we can see that New Hampshire is that part of that red piece up there where we have, relative to the nation, the highest rates of substance use disorder in this age group. So one of the things I did want to do today was sort of put New Hampshire in context for the research that I'm doing. And so, by the way, I show this slide in places where they don't know where New Hampshire is, so I'm like, oh, that's also right there. But within the state, I'm working on two ongoing studies of youth in transition to adulthood, one up in Coos County. Coos County, if you aren't familiar, is the northernmost county, the county with the largest land area and the smallest population. It's isolated from the rest of the state, tends to have higher rates of poverty, higher rates of unemployment, and so forth. So it's a isolated and sort of struggling area. And so I have data where we've been following youth up there. And then a second study that I've been working on where we've also had similar data where we've been able to look as adolescents transition into adulthood, what's happening with their mental health and substance abuse in Hillsborough County, which is the most populated in the state, has the highest and is considered a metropolitan area, and also some research from also Stratford County. So the sample I'll talk about in just a minute. So these are the two surveys that I've been working on. By the way, not by myself, lots of people collaborating with me on this work. But the first of the studies is the Coos Youth Study. This was a study of all of the 7th and 11th graders in the county, in county public schools in 2008, or at least 83% of them, which is almost all of them, right? So we followed them up 5 years later. So first in 2008, we had 657 of them. We followed them up into 2013. We got about 64% of them that we could follow up and kind of look at what's happening with them. The second study is the New Hampshire Youth Study. Ellen Cohn is the PI. She's sitting right here. It's a similar study we conducted that in 2008 had 7th and 10th graders, so they're a little bit younger. But we've been able to follow them as well from 2008 to 2013. We ended up with 52% of them. So we're able to follow and kind of see what's happening with these guys. And just to let you know, the analytic samples, the sample where I'm doing comparisons, it's about half and half. So it's about a little over 400 from Coos, a little over 400 from the New Hampshire Youth Study. And the mean ages, again, the New Hampshire Youth Study is a little bit younger, but for our purposes, still useful to analyze here. So these are the kinds of questions. I don't expect you to read through all of them, but we asked in 2008 things like to kind of assess a depressed mood, and these are based on symptoms that the American Psychiatric Association might associate with disorder. I felt sad, I couldn't get going, so forth. And we came up with a scale where we can measure depression there at 2008. And then we also asked questions about substance abuse symptoms in 2008 and in 2013 in both of the samples. So things like I was under the influence when I could have gotten hurt. I was trying to cut down but couldn't. Things that are associated with DSM diagnostic criteria for substance use disorder. For purposes of this analysis, people who just simply reported that they had, in the past 6 months, had one of these symptoms will be considered substance misusers or at risk for substance abuse or dependence. So in terms of comparing the two samples, first of all, sort of northern and southern New Hampshire, in 2008, the northern sample was statistically more depressed and had statistically higher rates, or they were more likely to report a substance misuse symptom than were the southern counterparts. But when we got to 2013, just comparing substance misuse, they look the same. They're very similar kinds of rates, whether we're looking at the Coos data or the Southern New Hampshire data. And so what those green bars are showing are the percentages of just did they report one of those symptoms. Those blue bars next to them are reporting whether they reported one of those symptoms and that they'd used alcohol in the last 6 months. Same thing for the yellow bars. This is they have used They report misuse and using marijuana, and then the last is painkillers. Again, trying to pull this back to thinking about how this informs the opioid crisis. So there weren't any differences, right? Until there were. So when we look at the effects of teen depression on substance misuse 5 years later, what we find is that those who are, first of all, this is showing us that people who are high on depression, so in 2008, if you're more depressed, you're at a higher risk for substance misuse in 2013, and that if you're in northern New Hampshire, you're at an even higher risk. So the effects of depression as a teenager, 5 years later, if you're depressed, then you're more likely to engage in or report substance misuse symptoms, and this is particularly true in the COAS data. And then when I just look at sort of, okay, was that just alcohol? We see a similar pattern, right? So if they misused and said they used alcohol. I looked at also for depressed mood, what's going on. Wow, you can see that really depressed mood in southern New Hampshire doesn't seem to affect whether or not you're misusing, you report substance misuse and marijuana use 5 years later. But also even painkiller use, we see a similar pattern. And for me, this is important because it suggests that maybe what we know about what's going on with other substances in terms of misuse might also help inform us in thinking about what's happening with regard to the opioid crisis, with regard to use of pain relievers. So really quickly, I want to stop talking because I actually want to hear from the other panelists. But basically, what I'm showing you here is that based on my research in New Hampshire, that teen depression is related to substance misuse 5 years later. And this is especially the case for the northern New Hampshire participants. And for me, this speaks to where we can put prevention efforts moving forward. That is, if we can really focus on the mental health needs of youth, particularly up in the North Country, where, by the way, we see fewer services in general. It's harder to get care there. This might be a place to sort of, for the next generation, to focus on trying to reduce this epidemic moving forward. So thank you very much. I'm very excited to have you all here. Here's my email. Please email me if you don't get to talk to me during the panel. I also have references, which you're supposed to have. And thank you so much for listening.
Our next presenter is Dr. Tom Sherman. He's a board-certified gastroenterologist who's been practicing medicine for over 30 years. And as a specialist in the Seacoast, Dr. Sherman is known as a brilliant and approachable resource in the medical community and has been a local resource providing compassionate care to some of the most vulnerable patients in our community. He was also instrumental in identifying and responding to a hepatitis C outbreak around Exeter, New Hampshire. And he's been recognized with numerous awards, including a Distinguished Advocacy Award from the American Cancer Society, the Knowlton Incentive for Excellence Award, the James E.C. Walker Award, and there's too many to list. Dr. Sherman has also been recognized as a top doctor by New Hampshire Magazine, U.S. News and World Reports, and too many other to list. In addition to his distinguished career as a physician, Dr. Sherman was also elected to and served 2 terms as a New Hampshire state representative. This upcoming November, he is running for State Senate Seat 24 to represent Greenland, Hampton, Rye, Seabrook, Stratham, and a few others. I missed them. I should have said them all. There's 11. And there's 11 towns in that. And are you actively recruiting volunteers for your campaign? UNH student volunteers? Always. Although Dr. Sherman has not held an elected position in the state for the last 2 years, he's continued his service to New Hampshire residents through work on the Seacoast Cancer Cluster Commission and Environmentally Triggered Chronic Disease Commission. He's also served on the Joint Task Force for the Response to the Heroin and Opioid Epidemic and the Commission to Study Expansion of Medicaid Eligibility. To me, what makes his career most impressive is his continued direct care of and advocacy for patients, paired with state service to care for our communities on a different level. Please welcome Tom Sherman.
Thank you. I'm not sure how this works. Forward, okay. Thank you so much. And actually, in the introduction to the lecture, I was kind of thrilled to hear the bridge between the liberal arts and what we do with the rest of our lives, because I was a classics major. So if you know what a classics major is, we study Greek and Latin, ancient history, and the biggest bridge between that and medicine is that I can actually understand the terms before anybody else. So my background, you've heard some of it. I'm not so sure about the brilliant. There's 3 keys to being a good consultant. And one is you have to be affable. That means you have to be somebody who can speak English and talk. Another one is you have to be available, which means your pager's always on, except for right now. And the last one is that you have average intelligence, and that's where I fit in. So what I wanted to share with you is, and I'm going to try to do this is typically much longer, and so it's going to be a really broad brush, and I'm happy to answer any questions afterwards. Is the combination of being a physician and a legislator, and I was explaining this at a door recently when I was canvassing, and it's like there's the micro and macro. My office experience with patients is the micro, and the experience as a legislator on policy that will affect the whole state, and in some cases, the whole country, which was some of the policy we came out of the hepatitis C crisis with, is the macro. And it's interesting to sort of see the parallels between the two practices. All right, you've seen this. But this is what got our attention in the legislature. The key here, and we've already covered this a little bit, is look at 2013 to 2017. It's huge. This is where we are now. I'm not sure you can read that, but as of July 24th, we've had 136 deaths in the state of New Hampshire. You may think, well, if you multiply that by 2, we're getting a much lower rate. But remember, all this data lags. So it's unfortunately and sadly, a lot of the deaths are still being, quote, processed. They're trying to find out what happened for sure and confirm that they were related to overdoses. But this is what got our attention in the legislature. The New York Times in January called New Hampshire the perfect storm. And I take credit because I said that in 16, but that's okay. They caught up with me. But the pre-existing factors in New Hampshire, and Tim Rourke, who is, I think, an amazing expert on all of this, will tell you the whole problem when it comes to the opioid addiction issue is addiction. And I see this in my practice. Alcoholic hepatitis, in my book, I see it more frequently than I see heroin overdoses or fentanyl overdoses. Mental illness is the setting in which so many of these, and you showed that beautifully, the connection, the coexisting illness is critical, and you cannot address one without the other. You can't address a heroin epidemic without understanding addiction. And when you look at the numbers, as you showed, addiction to alcohol, meth, crack, heroin, fentanyl, carfentanil, this is addiction. So, and then the real important one is legislative defunding. We used to have the single best mental health infrastructure in the country, believe it or not. Now we have the second lowest funding in the country. So the fact that in 2015 we were number 2, now we're number 3 for overdose deaths is no surprise when you see that we were number 2 from the bottom in how we supported the mental health workers and infrastructure and how much we spent on substance use disorders. The new factors, believe it or not, corporate America actually took advantage of us. I know that's hard to believe, but certain companies spent over $880 million on just marketing. They said OxyContin lasted longer than it did. They said OxyContin was not addicting, and they got through to physicians. I'm old enough to have been there beforehand, and we had a lot of respect for addictive substances. But a lot of the young doctors and providers were coming out of training. They were being wined and dined and being told how great these new substances were. And at the exact same time, and this is where the perfect storm comes in, the VA and a lot of the regulatory agencies were rating us and actually reimbursing us on the basis of how well we treated pain. So a 1 or a 2 out of 10, and they used to have smiley faces if you had no pain and a sad face if you had a lot of pain. All of these things were not only required for compensation, but they were also required for actually getting accredited, being approved as a medical facility. To such an extent that if you know what vital signs are, pain became the 5th vital sign. As a result, prescribing practices blasted off. And that's where that curve comes in. And then the final nail in the coffin, so to speak, was newer, cheaper drugs. Fentanyl came out. And that's what happened was people were getting their prescription opioids. About 80% of addicts on the street started with prescription opioids. And then these became cheaper. And in about 2014, 2015, they were being laced with fentanyl, heroin was. It was cheaper, easier to make, easier to bring, to not only to produce, but also to market. But it was also, people weren't expecting it. So they would cut their heroin with fentanyl. The drug user would get it, and fentanyl is about 1,000 times more potent than the heroin, and it would result in death. Carfentanil, the most recent, fortunately, has not seemed to take off as much. It's about 10,000 times more potent. So people didn't know what they were getting, and it was killing them. The legislative timeline, to her credit, now Senator Hassan called for a special session. To their discredit, the leadership in the House and the Senate at the time said no. To their credit, the Executive Council, which is our funky sort of group around the governor, said yes. So we had a special session, and we created the Joint Task Force on the heroin and on the opioid and heroin epidemic. And from that came a large barrage of, in fact, I've never seen the legislature so productive in such a short time. But I'll go through very briefly some of the most important legislation that came out of that. Since then, there has been some ongoing work. Much of what we have done, though, and I'll get to this in a second, is the state budget. What we are doing in New Hampshire is we're really heavily relying on the federal government for any money that we have, any resources we have for the opioid crisis. And I think that's a problem, since you saw that first quote. Which, what was it, the drug infested? That's the federal government. So anyway, moving right along. I think of the approach that we've taken, and this is what we used in the legislature, basically 3 pillars: prevention, treatment, recovery. Prevention, of course, is decreased demand and availability of opioids. Education, we passed a mandatory K-12 addiction training for all public schools. Reduce availability of prescription opioids, really, that is where one of the most effective efforts came from out of the Joint Task Force. I had the privilege of being in that group. We had the Medical Society, the Attorney General, the Governor's Office, House, Senate, and what we did was we set the bar for prescribing rules. Believe it or not, there are 7 different professional boards overseeing prescribing. So you can imagine what a variability there might have been, and that includes veterinarians. You might think, well, how can Pooch here abuse codeine? Well, if you take Pooch up the seacoast and you say, my dog has a cough, and you keep getting Robitussin with codeine at each veterinarian's office, all of a sudden you've got a nice supply of codeine. So the PDMP, which is the prescription monitoring program, allows us to track what prescriptions are being filled, and we changed that from something that was voluntary to comprehensive, which means you have to report when you're writing prescriptions and you have to report when those are filled. And then the prescribing rules bill. The great news is that New Hampshire in 2016 has the fastest rate of drop, fastest rate of drop of opioid prescribing in the country. So that bill worked and is working, and the balance has to be that people who really need the drugs can get it. In other words, if you have pain, you need to be able to get the medications, but we have to put in these checks and balances. My friend Jim Mosier, his wife Jean, lost their son Adam. Adam was one of the ones who had heroin laced with fentanyl, didn't realize it, and he died and they had no idea that he was addicted, no idea. Out of that, in a really amazing way, they've created this program called Zero Left, which is the idea is that your sock drawer, your prescription drug cabinet in your bathroom, all of these things will be empty of drugs. One of the places where people who are looking for drugs, they will go to real estate, open houses, and they'll go through your house and they will pilfer your drawers and your drug cabinets, and it's that amazing how intentional it is. Law enforcement, most police officers and most people in law enforcement will tell you that you can't arrest your way out of this. But we did make synthetic opioids the same class of felony as heroin. So that has been effective. But treatment, this is where we are with treatment. Less than 6% of the people who need it are actually getting it. Barriers, availability and coordination of services, drug courts, these are all things we worked on in that legislative session. Recovery is dependent on availability of programming, job training, housing, and placement. Effective treatment without a plan for recovery is not effective treatment. It just doesn't work. We know that from alcohol, we know that from opioids, we know that from every different type of addiction. Funding, my concern is that we are very dependent on federal funding. We're very lucky that our federal, the senators and congressional representatives have been able to get us large grants, but I think that is, I am always worried about the sustainability of that. So these are my ideas, not just mine, but these are where I would like to see some of our focus. And these are based on my knowledge of where the state of the art is on successful programs for attacking this. Treatment needs to be available at the most granular level. What that means is that you walk into your primary care physician's office, you walk into an urgent care, you walk into an emergency room with an addiction, and it should be able to be addressed right there. You don't need to go to another facility. It needs to be comprehensive. We need to wrap around, understand that there are a lot of factors. Mental illness, there are family factors, there are abuse factors, there are child factors, there are transportation factors. It needs to be comprehensive. It needs to be able to address all of these. Local, regional, statewide support and coordination with monitoring and feedback based on standardized metrics. Sorry. I was just trying to do a little gesture, and I think I just blew out your eardrums. When I do a colonoscopy, I won't go too deeply into this, by the way, we take off things called polyps. And I am actually rated on how many polyps, not just polyps, but the correct tissue of polyp that I take off. That's called an adenoma detection rate. There's no reason that we shouldn't be using metrics, not adenoma detection rate, but metrics to understand which programs are effective and which are not. And that requires an ability to gather the data and ability to successfully and meaningfully analyze it. I see as an end to the crisis, I see of all of this, the single most important understanding on the part of all of us. And I'm going to finish with this because this is where I'm super passionate, is to understand that addiction and behavioral health, mental illness are medical illnesses. This is not something we do to ourselves. This is not something that you choose to be depressed, you choose to be an addict. This is something that has true addiction, has neuro scientific changes in your brain, and we should treat it the same way we treat diabetes, hypertension, heart disease. So I would love to see in my world, when somebody comes into the ER with an overdose or alcoholic hepatitis, we wrap our arms around them the same way we do our neighbor or friend who comes in with a heart attack or with a code. If you know the difference between the responses right now to both of these problems in most emergency rooms, you'll get what I'm saying. And from my knowledge of the studies, if we treated addiction and mental illness with the same resources that we treat what are, quote, medical illnesses, we would have basically the same outcomes. But we don't. And that's where I think we're failing our neighbors and our friends the most. So if there's one change that everybody in this room can make, unless you already are there, is to think of it as a medical illness. And that will change your whole paradigm in how you think about an appropriate response. It might be more expensive to do that, but we're going to save lives, we're going to improve lives, and we're going to return people to productive lives where they have families, they have houses. This is something that we can do. Thank you.
Our third presenter is Kevin Irwin. He currently serves as the Director of Operations for the Region 6 Integrated Delivery Network, or the IDN program, locally. It's a Medicaid waiver program aimed at building capacity and new models of care to integrate behavioral health, primary care, and social services. Bear with me, Kevin does a lot as well, and there's a lot of long committee names coming. In New Hampshire, Kevin currently serves on the Governor's Commission on Alcohol, Drug Abuse Prevention, Treatment, and Recovery. As the chair of the board at Hope on Haven Hill, a transitional housing and support program for women who are pregnant and with infants. He is the chair of the New Hampshire Harm Reduction Coalition, the commissioner for the Dover Housing Authority, a member of the steering committee of the Greater Seacoast Coalition to End Homelessness, and former chair of the advisory board for SOS Recovery Community Organization. After working as a substance use counselor, Kevin served as a research associate in the Yale University School of Public Health, as faculty of the Community Health Program at Tufts, and as senior program manager for the Corporation for Supportive Housing. Over the last 25 years, he's been working at the intersections of public health policy, research, and practice as a teacher, researcher, consultant, and advocate, always focused on improving the health and well-being of vulnerable populations. Throughout his career, he's worked closely with people who use opioids and the programs that serve them, including expanding access to quality medication-assisted recovery, building and supporting syringe service programs, and community-based naloxone or Narcan access. This work's taken him across the globe, including the Russian Federation, India, and Brazil. Additionally, I can attest to Kevin's expertise as a mentor, a convener, and an instigator of positive change through our work together on syringe service programming and harm reduction in efforts in the state. Please welcome Kevin Irwin.
Thanks. Thanks, Carrie. I feel like I can only go downhill from here. So I'm gonna be talking really fast because it's already 6:15, and I want to leave plenty of time for a panel discussion. You're going to hear a couple of data points that you've already heard. But when I saw the kind of kickoff for the lecture series, Why New Hampshire, I'm a sociologist like Dr. Van Gundy, so we're always thinking big, right? We're always thinking, like, what are all those kind of social factors that shape an environment and the risk in that environment? So the question for me, I just moved to New Hampshire 4 years ago, by the way. So I'm thinking about this, like, what did I see when I got here? It raises a couple questions for me. How did we get here? Of course, I do want to talk a little bit also about where do we go from here. I have to do that. I start really just going to tell you some stories, right, about where I've been and what I've done, because the question for me when I think about New Hampshire is, where did I see this before already? because I have, and we all have. In the 1990s, I was a provider, drug use, substance use counselor, also did a lot of outreach, did a lot of work in the street in the Northeast and on the West Coast. And back then, of course, crack cocaine was the epidemic at the time. So it's a story of supply and demand. And that's kind of the common thread throughout what I'm going to talk about for the next few minutes is that supply always meets demand. So the question is, what drives demand? Well, in the crack epidemic, if you will, demand was driven by really a lack of opportunity, right? So you all know that the crack epidemic disproportionately affected African Americans, black populations, folks in the inner city especially, and a certain amount of kind of racially infused drug policy. And so all of those things kind of conspired to really drive folks out of opportunities for social mobility. And we had really poor treatment access. Like evidence-based treatment for crack is almost non-existent. For amphetamines, back then especially, I was a treatment provider. We really needed treatment for co-occurring disorders. There was nothing. Like I can remember working, and we were we were making it up, like as we went along. But at the state level, the alcohol people were over here, and they had all the money, right? And then you had the substance use people were kind of over here, and they had a little bit of money, and the mental health people were over here, and they had a lot of, so they never talked to each other, ever. So it was really hard to integrate care. So we didn't have much of that. We didn't have what people needed at the time. But supply was really efficient. So that's what crack is, right? It's a much cheaper and easier to use formulation of a drug that's in demand. And the more demand that built up, the more it was there to meet the demand. It became more affordable. $5 rock, right, at the time was easy to access for almost anybody, right, rather than a $100 gram of cocaine. And in a really depressed kind of situation in market, it's also a market opportunity for folks who don't have access to a wage-paying job. So, we saw terrible consequences, rapidly increased prison population, which only, decimated families, really tore apart community infrastructure, and had really negative impact on the population. So that's the first time I saw this. The second time I saw this, I was working in Russia for a few years. We were over there really studying opioids. Heroin use had increased precipitously, so it seemed, but really HIV use increased precipitously, so we want to understand why. It was almost all driven by injection drug users. All of those folks used and made their own drugs, right? Really educated, clever folk, and very good at that. And there's plenty of poppy in Russia. And so we're trying to understand why all of a sudden is HIV increasing. The narrative was that people were adding blood to the mixture. So if you had HIV-infected blood and you add it to the mixture, then that's what better vector, right, than to stick your needle in there and stick it in your own veins. So we know that demand was driven by, in post-Soviet Russia, right, after you move from socialism, a new market structure that through early capitalism, some people get left behind. A lot of people got left behind, right? So the opportunity structure in the new market economy of Russia was very, very unequal. Very, not only poor access to treatment and recovery, but for opioids in particular, methadone and Suboxone were and still are illegal. So that's really poor access to recovery, right? And supply, absolutely. I'm going to tell you the story about how supply was met, but this supply did meet demand, also as a market opportunity. And I'll tell you a little bit about the consequences. So what we did was go to 11 different cities in Russia. We spent time with and interviewed about 850 active injectors to understand like what's going on, why the HIV rates, how does heroin get produced, what are the health consequences. So I learned a lot about how to make heroin. No, you can't ask me after the series, but there's lots of different ways to do it, but there's kind of a core standard set of recipes. So folks would get together in small groups. This process takes 2 or 3 hours. It's a small group process. It's very social. Everybody contributes something, and everybody uses together. But as long as nobody in the group has an infectious disease, well, that's kind of protective, isn't it? Right? And very low rates of overdose. Right? So what changed? Like, why was their HIV rate going up so much? Well, we also know at the time in post-Soviet Russia, new market economy, the borders opened up, right down, is there a laser thingy?
It's not great, but I'm good at that.
It's not very good. So anyways, you know, what's right down here? Afghanistan, Pakistan, right? So commercial grade heroin, right, that looks much different and is used much differently. Ooh, thank you. Starts coming across the border, right? So, and again, market opportunities. People that are not part of the new market economy can make money doing this. And so what we found was in those cities where commercial grade heroin really started to take off, well, that's where the problems were, right? So in those cities, overdose mortality went way up. Stop me if you've heard this before, right? Rates of hepatitis C skyrocketed. Rates of HIV skyrocketed. Incarceration skyrocketed. And so by the end of around 2008, 2009, Russia was consuming about more than 20% of the heroin worldwide. Okay? And rates of overdose that eclipse what we see here. So where else did I see this? Well, I saw it in Maine, actually. We were doing a study in Maine in 2002. The whole object of the study was to understand, as OxyContin had started going crazy, right? How do we understand the use of OxyContin in the context of substance use in the community? So we did a study up in Cumberland County, which is essentially Portland and surrounding communities, and Washington County, which looks a lot like Coos. It's about 32,000 people, very little treatment availability. There's lots of stoop labor, raking blueberries, digging clams, stuff with tough work, a lot of chronic pain, okay? So we're doing both of those places. We're interviewed about 237 people. And we wanted to understand, is OxyContin like a gateway drug? Right? That was one of our questions. We had a number of research questions. Did a very long interview with folks, and what we found there, CASEM is Community Assessment of Substance Use in Maine. 40% of the folks that we talked to did report recurring pain that interfered with their daily living, but for most of those people, right, the misuse of opioids preceded the onset of chronic pain. Right? So now you got a problem, right? So you got more people with chronic pain who are engaged in treatment. OxyContin users could only be distinguished from heroin users controlling for non-heroin opioid users, okay? Which means polyopioid use in the first year of initiation, whether it was OxyContin or not, was associated with much more rapid initiation of injection drug use, right? And why is that? Why do people inject drugs? Maybe we can save that for the discussion. Let's think about that. Why do people inject drugs? And then non-medical users of OxyContin were not distinguishable for non-medical users of other opioids. So OxyContin took a really strong place in the market, but in the market of lots of other drugs, right? Lots of other drugs. And OxyContin at that time, back in the day, was really expensive. Like it was $1 a milligram. So one pill was $80, right? So that's a little bit of a hint of why people inject drugs when we come back to that. So after that research and over the next several years, we started to understand a little bit better the relationship between chronic pain and opioid misuse. and the risk for addiction. And now it's kind of well established that risk for addiction is less than 8% for folks who are prescribed opioids for pain, right? A little counterintuitive. Since 90% of all addiction begins kind of in earlier life, as Dr. Van Gundy was saying, the risk for adult is even lower, right? And this is a review, you don't have to take my word for it. This is Nora Volkow, who's the director of the National Institutes for Drug Abuse, published this in the New England Journal of Medicine. So there you can see where folks get their opioids from. Few folks obtain prescription pain relievers from one doctor. Multiple vets. Okay, so now finally I moved to New Hampshire. Sorry about the long story, but that was that's my experience when I got here, right? I came here, I saw a lot of the same stuff, right? How did I see the same kind of social context about lack of opportunity? Well, one of the things I noticed right away over here on the Seacoast, we got a lot of folks who are really unstably housed and homeless. A lot of folks who make very low wages. The hourly wage that's required to afford a 2-bedroom home, anybody here know what the hourly wage is? $22.32, right? And there's a boatload of people that make between $9 and $14 or $15, right? So, and if you only made minimum wage, how many hours would you have to work in a week? Any guesses? Only 123 hours. Okay, so that's, as Dr. Van Gundy was talking about, kind of the precursors of depression. If your expectations for social mobility, for being able to do better and buy a house or get a house where your whole family can live, is constrained by this opportunity structure, that's a difficult context. Another thing, this is just an example of our underfunding of prevention, treatment, and recovery in New Hampshire. So we have this thing called the Alcohol Fund, right? The Alcohol Fund, you know that the state sells alcohol on the highway, which is just such a good idea, right? And the proceeds from that, the profits from that, Judge Gordon led a charge around 2000 to create the Alcohol Fund so that some of the proceeds, some of the profits from that would be directly invested at the time, mostly in treatment. It's been expanded to prevention and recovery since. And it's been expanded from alcohol to all substances. So 5% of those proceeds are supposed to go directly to the Alcohol Fund for the state to reinvest. So just like Dr. Sherman was saying, it would be great if we could be more confident that the state would put dollars into this problem. This is a mechanism for doing that, but Congress had managed to appropriate most of that money every biennium. And you can see how much money they raided, if you will, from the Alcohol Fund. So over these years, from really it didn't get started in until 2003, until the biennium of 2016-2017, where we should have benefited from $100 million invested in prevention, treatment, and recovery in New Hampshire, we came up short by $63 million. This is just one program. Right? So when we want to think about social context and what could be preventing what we're seeing today with opioids, that's part of the answer, right? This is just a different chart so that you can see how far apart those are. Another place, we've talked about mental health services and how important they are. Certainly we had lack of parity. The community mental health centers today are getting the same rates that they received in 2006, right? So a $100 reimbursement in 2006 is only worth $75 today. But you have to pay people higher wages, and you have a much higher overhead and indirect and cost of running your services, right? That's a big problem, right? And when Medicaid managed care came on board, we had to transfer over 10% of the dollars that CMHC's got into the managed care organizations. So a huge undercutting of our mental health services across the state. Likewise, as Dr. Sherman had pointed out, we've lost not only in mental health, but substance use treatment has really diminished over the years. 14 programs were shut down in the 1990s. 4 to 6% access for people who want services, can't get them. And then medication-assisted recovery, we have nowhere near the number of prescribers that we need, right? The other thing we don't have a lot of is outreach and engagement kind of programs. So currently we have a couple syringe exchange programs and health services programs who go out and meet people where they are. We have some pretty good programs. We're getting a little bit better at serving folks when they walk in the ED. We have these things called safe stations. But most of the folks who may want or need assistance are not going to go get it. We have to go out and touch them, right? So syringe services are something we've needed here forever. A very good friend of mine was doing syringe services in Nashua in 1993. This is not a new need. He got run out of town in 1993. Some 23 years later, I'm sitting on a syringe commission trying to get legislation passed to do the right thing 2 decades too late. We've talked about fentanyl, benzodiazepine as well, and it's important to understand that most of the people who pass away from an overdose have multiple drugs on board. It's not only opioids. You already saw these data. And we got the response that we invested in, right? We're lagging in integrated prevention, treatment, and care. We suffer from this tyranny of kind of simple explanations. Like if we could just do the one thing that'll make everything better, it's a really complicated problem and it requires complex solutions. And we created a market for fentanyl, right? It didn't exist before. We created the market for fentanyl. And now we're at the point where we can move 200 grams of fentanyl, right? That's 6,600 doses of, I can put that in my sock, right? So you think about those guys making their own heroin, right? And how much it takes to make plant-based narcotics and ship them across continents and so forth. This stuff, piece of cake, right? So that's the new normal. There's a little study, I'm going to shut up in 1 minute. There's a little study that contemplates if you model all the different kinds of things we could be doing, what should we be doing? Naloxone availability. Naloxone is not new. We were doing naloxone on the street in 1998, right? There was only one formulation. You stuck a needle in it, you stuck it in somebody. You could stick it almost anywhere. Like it's the easiest intervention ever. It cost $1. $1. Now, pharmaceutical companies have figured out how to capitalize on people's anxiety about needles, and it costs $40, $80. Now we have one that talks to you and tells you everything that's, what, $500, $600. So absolutely absurd. But increasing naloxone availability, medication-based treatment, psychosocial treatment, needle exchange itself, acute pain, prescribing, drug reformulation, opioid disposal, getting rid of stuff you're not going to take, transitioning folks. And then there's counterintuitive stuff that this study, and I would encourage you to read this study, says that sometimes, and there's a lot of caveats to these, but if you do drug rescheduling and constrict schedules more, or the PDMP itself, if it's not done the right way, then you move people outside of the medical care setting, which is where we want them to be, and they're more likely to go buy on the market where they don't know what they're getting. And you actually end up with more deaths. So you have to be really intentional and systematic about doing exactly what Dr. Sherman was talking about. I hope we stop calling it a crisis, please. Like, if we're not going to treat it like a crisis, don't call it that. We have a crisis of non-response, That we have, but it's not an opioid crisis, right? An epidemic, I don't understand it as an opioid epidemic, but that's another topic altogether. We're trying to build integrated systems of care. I can talk to that a little bit in Q&A. It's a difficult thing to do. And now we're all over opioids, opioids, opioids. We have a new state opioid response grant. We got millions of dollars coming in. Guess what? It's too late, right? It's too damn late. Most of the people who are presenting right now for inpatient treatment over at Southeastern Services, they're using stimulants. Totally different ballgame. My hopes also are that we build a recovery-oriented system of care. In addition to 20 million people who may be suffering from addiction, we have more than 20 million people who are in recovery in our country. I'm one of those people for about 29 years now. Recovery does work, but you have to build a system that supports recovery, and not all of those people got treatment. They got support from their community and other sources. So I'm keen to build that as much as we can. And I'm sorry I talked too much.
Well, thanks so much to all of our presenters. We're going to open it up for questions. What I will ask, I'm sure we've all been to panels where either panelists speak too long, questions go on too long. If I think that you're going on too long, I'm just going to put up my hand and just give you a little nod. Same goes for question askers. And I'm going to take the abuse my power to ask the first question. So all of you have talked in different ways about youth exposure being really important. And I am curious from each of you what you think a good intervention would be for the state to support, to fund, to address youth trauma, adverse childhood events, and many of the factors that we saw in Dr. Van Gundy's presentation. Who'd like to start?
I'll start. I'll start. My mother was an early childhood therapist, so fundamentally, I think we start as early as we possibly can with sport. And I know that sounds maybe a little bit too young. I don't think there is too young. What we're seeing in terms of kids being raised in New Hampshire right now, if you look at child abuse, the map of child abuse in New Hampshire, and you take the map of substance use, they fit. So this is a whole generation at risk. And I would be interested in seeing, and I'm not sure if it exists, but I'd love to see data at how early is it possible to identify a child and predict later substance use. So I don't think we can start too early. And I would love to see a program where, we were talking about this before, where you start with, Mama Sherman would say, you start somewhere between kindergarten and fourth grade, because we don't have statewide pre-K. And we build a system where teachers, every good K through fourth grade teacher knows which kid is at risk. They do. And we start supporting those children early. We see this in other developmental disorders, where the earlier the intervention, the better. And then we have this program of training for addiction, not training people to be addicted, but training about addiction that's required. I'd love to see that be also training for how do you develop circles of support? How do you start developing friendships and using your community and in ways that are constructive, and identifying the kids who are at risk of not being able to do that. It sounds huge in terms of the enormity of the project, but it could be a system that exists in all of our schools. That's where I would start.
I'll go. I've thought a lot about this. So a lot of the research that I'm doing, especially up in the North Country, is looking for what we can do for people who are more at risk. And one of the things that we're finding is, so for instance, that we know that exposure to trauma, exposure to stress, these kinds of things, these things that happen early on can have long-term ramifications. We know that, for instance, in Coos County, that there's a proportion who are just really poor, and there's their poor families, and these aren't just individuals, and that's where we're going to see a lot of that stress and strife and so forth. What we're also seeing is that feeling attached to your community, others attached to your family members, even your siblings, these are very sort of protective things, and in fact can buffer the harmful effects of these stressful things that we're seeing. So as an example, I published some work looking at data from both northern and southern New Hampshire, where so we looked at the people who were had the highest levels of stress. So these are people who are really encountering a lot of terrible things in their life, and that increased their risk quite high. It makes them much more vulnerable to some of these things later on, unless they're attached to their communities. So if you are someone who has this high level of stress, or you're in a very poor family, or so, that attachment piece can buffer that. In fact, the kids that are really super stressed out, but also feel connections in their community, those kids don't have any higher risk than the kids that don't have a lot of stress. And one of the things too, again, looking at that, is that family support. And again, support even not just from parents. A lot of these are families that are struggling, but siblings even can be a really important resource for helping deal with things. A lot of times, we're looking at parents who maybe aren't able to take care of their kids for what they're undergoing this stress as well. But sort of drawing not just on schools, but sort of thinking about where we can find supports in the communities and the families and so forth, where that's going to hopefully at least buffer. We may not be able to reduce all the amount of stress, but we can come up with solutions that we know will sort of ameliorate that stress.
So I don't know if I could add much to that. I mean, I agree with both. I guess what I would add, part of recovery is adopting or being supported to adopt a meaningful role in the community. And so I think that's really what we're talking about here, is you don't have to wait until recovery to do that. And I think you see that kind of ennui or that kind of social disengagement, I think, among young folks a lot now. I'm not going to blame cell phones, but much less kind of just go outside and interact socially. And it is literally very different, I think, to grow up now. I have a 38-year-old kid, I have 36-year-old kids, and I have a 7-year-old. And it couldn't be more different to raise a child today than it was 38 years ago. The other thing I would plug for are prevention programs that are based in reality and fact and accurate information. So Marsha Rosenbaum is one who's created wonderful kind of drug education programs for schools that you hear from people who have expertise. You get accurate information about substances, what they are, what they do, how they interact. And I would contrast that against DARE, right? And I have lots of family members and wonderful friends who are in law enforcement, but it means something different when you're going to learn about drugs and the person teaching you has a badge and is reinforcing the idea that it's a criminal justice issue. It's not, it's a health issue. So let's treat it like a health issue. And that kind of curiosity and the mistakes that we make as young people become diminished when we have accurate information. Doesn't mean we won't, try stuff out, but we're at least going to be a lot more informed about how to keep ourselves safe.
Thank you. Question from the audience.
First of all, thank you very much for your informative presentations. It was really interesting to hear these different perspectives.
Can you guys hear in the back?
You have to repeat the question.
I can try to talk louder. I'm very loud.
Sorry, let me.
Thank you. So I'm active in a number of statewide suicide prevention and mental health awareness efforts. And I don't know if any of you have come across, but there was a recent study out of the Bureau of Drug and Alcohol Services that looked at mental health and substance use and misuse among New Hampshire young adults. And they found that one of the continuing barriers to treatment, in addition to some of the things that you were all talking about in terms of access, was the stigma associated with coming forward and acknowledging substance use disorders or misuse patterns. So I was hoping that maybe you could talk a little bit about, in each of your roles, if you continue to see the negative effects of stigma, and if so, what you think could be done to kind of combat that and help people feel more comfortable and confident coming forward for treatment.
I could speak to that. Or I'll start. I think we've learned a lot in the past about how we could approach stigma and discrimination, and I think there's a lot of discrimination that we need to disentangle from stigma. In particular, from I was an HIV/AIDS worker for years, and certainly we learned a lot about how communities can come together and cultivate advocacy. And be out about these issues. And I think since I moved to New Hampshire, I've seen, more self-disclosures. I lived in New Hampshire, actually, when I sought treatment almost 30 years ago. I got treatment. I had to go out of state to get treatment. And when I moved back, I became a single parent, and so I needed a recovery network and a lot of social support to be successful. And I couldn't find that in New Hampshire. I was up north. And so I actually left the state and went back home. And so since I came back, the recovery movement and the number of people who are out about being in recovery is massive. Like this just didn't happen a few years ago. I've worked in vulnerable populations in communities all over the place. There just aren't really loud and proud recovery communities in many, many places. So I think when we put recovery on Main Street and let people know that recovery is possible, and that it's okay to talk about addiction, it's okay to talk about substance use, that helps to, at least open. It's all about having a conversation in the first place. You're not going to change everybody's mind, and that's fine. We don't need to, but at least we can have that conversation.
And I would like to add to that. So it's not just the community. I was at a conference, the American Sociological Association conference, and it was a couple of different sessions looking at the opioid crisis. And one particular that stigmatization happens in the medical field. In fact, that even within that, that it is not typical to be supportive of medication for treatment and so forth. I think it's becoming increasingly so, but I would say it's the community, but it's also the medical community that needs to really sort of be on board. I would say, I don't know if that comes from education and so forth, but that's a piece. Again, we've got exceptions here, of course, people that are obviously understand the problem, but it's a lot of misinformation, and people even feeling like if they are contacting the health services to get the help that they, depending on where they make contact, that can be a very certainly stigmatizing and discouraging kind of piece.
And nice segue into the medical community. I think this goes back to sort of what I was talking about in terms of thinking of this as another medical illness. If you could walk into your family's practice doc and that family practice physician had as much training and background in mental illness and substance use as they had in diabetes or hypertension, you would have a completely different experience in that office. If they were absolutely facile with the ability to treat with Suboxone or methadone and pick, just like they're able to pick hydrochlorothiazide, or the paradigm is the same. So what we see, though, is in some of the enlightened ERs, like I would use CMC as an example, for a while there, and I'm not sure the program is still in existence, but I'm sure some form of it is. If you came in with an overdose, you did not leave without having a recovery coach assigned to you. Other ERs in the state, you are almost persona non grata. Narcan, you're stable, you're on the street. So that huge variability, I believe, is not because the doctor in one ER is more caring than the other. It more likely comes from exactly what you're saying, which is not understanding the physiology of addiction and also not understanding that appropriate treatment is actually effective. You know that's true of suicide. Tara Ball and I have talked about this at length, that when it comes to behavioral health and mental illness, again, it's applying appropriate treatment has incredibly good outcomes with depression. And so part of this is bringing the medical profession up into the 21st century and not thinking of it as a separate specialty. A family practice doc should not just be good at internal medicine. They should be good at the component of psychiatry, psychology that would be a part of any practice. Should be a part.
So Dr. Van Gundy, when you ran the study up in Coos County, did you include like vaping and like teen vaping in this substance misuse?
That's a good question. No, we have questions about it. So the way in which we're looking at this, again, we were asking questions about if they'd used any substance, then we asked questions of, okay, did your alcohol or drug use interfere with your ability to perform roles, so forth, that sort of thing. For these analyses, I don't look at, I think of, and by the way, there's high rates of use of nicotine, and rural areas are especially high across age, and Coos County is no exception. I almost feel like that's something to look at in its own right, in sort of a different way, and it's something that I'm planned to do. But it didn't make sense to say, well, I was vaping and that interfered with, I was under the influence of nicotine while I was driving a car. It's sort of a different kind of a thing. But we have all kinds of questions about various ways in which people are using tobacco, and so we just haven't had a chance to analyze that yet.
Another question?
So I have a question for Dr. Sherman. You referred to drug addiction as sort of a mental illness because it changed the function and altered the brain. So what would you say to someone that argues that the function of the brain is to change and that's how we grow and learn?
Well, that's an easy question. Just kidding. What I meant to say was that it's the neurophysiology of the brain, it changes with the use. There is, in fact, UNH has some of the leading scholars on this. The idea is that you actually have a physical chemical change in the makeup of your brain in response to opioid addiction. That can be shown by scanning the brain. It can be shown by looking at substances within the brain. So what I'm talking about is that there is an actual physical response of the brain to opioids, to addiction. And it's not clear whether that's actually reversed when you're in recovery. So this is a potentially permanent change in the neurophysiology of your brain. So I'm not sure I'm answering your question. Addiction is, when I talk to people about it, I say, well, just like cigarette smoking or other issues where we know that the substance is addictive, there is a choice that's made when you decide to do it. But after that choice, once you're addicted, the medical model applies very well, and you actually see physical changes from tobacco, you see physical changes from opioids, and those can be measured. So that's why I think the medical model works. I'm not sure I answered your question very well, but if I didn't, there you are. Is that what you were getting at, or?
Yeah, somewhat, because, in our class that we read a book from I think it was a neurobiologist or some sort
Neuropsychologist or
that studied the effects of addiction on the brain, and it was very similar to how the brain changes itself through when it's growing up and when we're learning, how neurological connections are destroyed and remade in different areas, and sort of when addiction is, or when drug use is repeated over and over and turns into addiction, it turns into a compulsive habit. It behaves like a habit where the person using the drug no longer really has control over it. So I was sort of comparing how the author of that book, the actual purpose of the book was to try to debunk the disease model of addiction, sort of promote it's more of a habit and the biology of the brain is to change. So I was wondering what
Yeah, I guess what I'd say is I disagree with that premise. We have many studies that show that successful wraparound treatment of addiction is successul. I'm not sure how helpful it is to think of it as just a habit. And I know very few people who are in recovery, and might be able to get a better answer from somebody else, who would say, well, I just had to kick the habit and I was no longer, and I'm past it now. It's every mantra that I've worked with in my patients who are alcoholic or in recovery from drugs, it's a daily process. It's a daily conscious decision. And that's different from a habit like biting your fingernails. At least that in my world, I don't find it terribly helpful to think of it as a habit because I'm not sure how to respond to that.
Kevin or Karen, do you want to comment on that before we move to a new question?
No, I don't need to comment on it. It's my class.
I would just say that I always...
I'm glad they commented.
You assigned the reading.
I did.
So you read the book.
That's good.
I always think of addiction in terms of it's a biopsychosocial condition, right? And those three things are always intersecting. And for some folks, the kind of short-term or long-term effects on the physiology of the brain is different. Depends on what do you come to the table with, what are all the other factors at play. Yes, the brain, neuroplasticity and ability to recover is amazing, but it doesn't always happen for some folks who literally do damage. But it's always complicated.
Okay, and I will say something. That is that even in the book, many argue that okay, if we don't characterize it as sort of an illness, as a disease, people aren't going to get the help that they need. But he also presents some evidence, and basically that a lot of folks they don't get much out of the sort of traditional recovery, that most people recover on their own from any addiction, and that in fact they aren't just recovering, they're changing and growing. And so he makes this argument that it isn't, it's not drugs aren't changing, that our brains are changing all the time in response to things that feel good, that we desire and so forth. This is a really accelerated learning in this case, but that it's not permanent, and that there's research to suggest that you can create that neuroplasticity can continue to sort of grow, and that a lot of people even who have recovered aren't who they were before. It's not like they've gone back. It's more that they've grown now in this way. And I think that, again, I get your point, and I'm also not saying whether or not I support either point of view, but that I think that's what I think we're trying to get at here. But your point about characterizing it as a disease in order to be able to treat it, I think, is an excellent one.
I have a question. I heard Dr. Irwin say that certain programs like Safe House, the Safe House program, actually may not be as effective because it's hard to get people who need services to come in the door. So I was sort of wondering about that. How do you get people to come in the door? What kinds of services and outreach might be most effective?
So the point I was trying to make is get rid of the door and go meet people where they are, right? And so, for example, Hand Up Health Services, the syringe program we started here in the Seacoast, We've touched hundreds of people who are actively injecting drugs who otherwise would never have been touched if it was required of them to walk into a place. So people have lots of reasons why they may not want to walk into a particular bit. They've, back to stigma, they've been treated poorly there before. They don't want to be on camera. They don't want to be in bright lights. There are lots of reasons that folks don't go to an institutional setting to present. And so the more we can build relationships and make connections with folks so that they have a trusted person to reach out to when they're ready for help, and we can respond to it when they're ready for help, we increase the likelihood that they'll get help exponentially.
So it's just about 7 o'clock. We're going to have one final question, and I hope the panelists can stay for a few more minutes for additional questions that we weren't able to address in this. For our last question, does anyone have one that involves all three panelists that we can end on?
I was curious on what your thoughts were on Narcan and like how available it should be to the public, or if it should just be a thing that paramedics should be able to carry around, and if it enables, I guess, bad behavior with.
So I have really strong feelings about this. So Narcan enables people to stay alive. That's all it does. Narcan has no physiological effect whatsoever except to reverse the effect of opioids on the mu receptor of the brain. So it kicks them off. It doesn't do anything else. We could all take Narcan right here, right now, and as long as you're not taking opioids, prescribed or unprescribed for any reason, nobody will feel an effect. So it's the safest possible, it's the easiest public health intervention. And I do a lot of public health work with a lot of really sick people who have many comorbid conditions. You don't even need, we've done studies. You don't need to do a study. It's a pre-post study, Somebody's dying, you give them Narcan, they're alive. That's it, that's the study, right? So we don't have to control for anything else. So as I said before, we were distributing Narcan in the street. Now, what we want to do to increase access to Narcan, right, is reduce the barriers and threshold to access. So if all we can do is call an emergency service personnel or put somebody in our car and drive them to an emergency department, we're going to lose many more people, and that's the way it always used to be. And folks wouldn't call 911 for very good reasons, because the police get alerted. So that's why you have Good Samaritan laws. My, real disappointment with naloxone is it's been off label for years and years and years. Like I said, in the 90s, it was $1. Like it was less than $1 for a dose of Narcan in a vial that's this big, so it fits anywhere in your sock, your pocket, behind your ear. So, and there was always kind of anxiety about the fact that you had to draw it up and inject it. Well, let me tell you, folks that are injecting drugs 14 times a day, they're okay with a needle. It's not a problem. So it's pretty easy to do. It's also great for everybody who knows somebody who's at risk or who is at risk to have naloxone on them, because the first responder in almost all cases is not an emergency service personnel. It's the person that you're using with. It's your mom who's on the other side of the bedroom door. It's somebody who loves you or cares about you, and somebody who can administer naloxone very easily. So it's a shame that, as I said earlier, kind of our anxiety about needles has led to this whole new market opportunity where the state of New Hampshire, right, over the next few years is going to spend hundreds of thousands of dollars on intranasal naloxone that we could be spending on prevention, treatment, and recovery.
I would just add that there are a lot of people who are frustrated by naloxone. And they're frustrated because they're riding in the back of ambulances, they're paramedics, and they will do 3 reversals in a day or in an hour of the same person. So they'll reverse the opioid, they'll use again, they'll reverse the opioid. But the fundamental, I agree 100%, is in the end, what we're doing, not we, but what is happening with naloxone is it's life-saving. And so there's an awful lot of people who are very upset, understandably, almost to the level of PTSD because of their experience in law enforcement or paramedics. But it doesn't change the studies that have shown that this is an effective life-saving tool in people who are addicted, and it's part of the package of naloxone. One caveat to that, which is I find kind of interesting, is the double standard we have for naloxone. When I do, back to the colonoscopy, when I do a colonoscopy, if I have a patient who has had a little too much opioid, we'll reverse with naloxone. I haven't had to do that for about 20 years, but when we do, the hospital policy is that we have to monitor them for another 6 hours. So one of the problems with naloxone is, depending on the dose of opioid that was given, is that the person can relapse without even doing another injection of an opioid. So we have sort of this double standard of what do we use in the field and what do we use in the hospitals, because we understand that we can't let somebody go out who's been reversed, who has been getting fentanyl for a procedure, but we let them decide not to go on an ambulance when it's in the field. And I think that's a discussion worth having. I don't know the answer, but I think it's a discussion worth having.
And I also, I don't have it as much experience with this, but I tend to be very much in favor of public health outreach, and that when we're even talking here, that it shouldn't only be medical professionals that are, paramedics that have this, and in fact we would probably see that family members, so forth, can do this. I don't know how that looks. I'm not sure how that, what the policies are regarding that, but I would tend to be in favor of, yes, if it saves people's lives, we should have access to it.
Yeah, so the bottom line is dead people don't recover. We know that, and which is a little bit of a provocative statement, but you really have to remind people of that sometimes, because as Dr. Sherman said, there absolutely is compassion fatigue. I mean, there's a lot of secondary trauma involved with reversing an overdose for an individual. Sometimes, this is your neighbor, it's your neighbor's kid. I mean, it's tough. So we do a lot of trainings. Used to call it compassion fatigue. Now we just try to call it building resiliency. How do we support each other to continue to keep folks alive until they're ready and able to get better?
Thank you, and thank you to all of our panelists. For all of the students that are here, I think as we've heard tonight, there's so much complexity, and there's so much that we can do, that we do now, but there's a lot of missing links, like after reversals, where those supports and services are and how we get them out. And so, especially growing up in an age of technology, from pretty much day one, your charge is to help solve that and to help us address that, and to fix some of the problems that have been created around this, around lack of social support and community. So anyway, I hope you'll join me in thanking our panelists for joining us.